Good evening, everyone. Good evening, everyone. If it's audible and visual is clear, should start then. Good evening, everyone. If it's audible and visual is clear, should start then. Okay, so we start with the twins. Okay, so we start with twins. First of all, there are two type of twins: dizygotic twins. Dizygotic, in which ova is fertilized by sperm, and then another ova it fertilized by another sperm. Okay, so that is dizygotic, in which two clear zygotes are formed from the very first day. So of course these will be having separate chorion and separate amnion. So all the dizygotic twins are diamniotic and dichorionic. Is it clear? What type of twins are produced in most commonly in ART, artificial reproductive technique, in IVF, in ICSI? What type of twins are produced? Come on, write down in the chat box what type of twins are produced. A PYQ it is. Good evening, Dr. Rachna. Good evening. What type of twins are produced in ART? Please write down in the chat box what type of twins are. Yes, they are dizygotic. What we do in ART, in IVF and ICSI, what we do, we implant, we get more fertilization done, so that at least one fetus we get. So this was a PYQ. What are type of twins are in the ART? ART is IVF, right? What type of twins we get in ART? Okay, what type of twins? I think there's some problem. Let's shorten the screen. What type of twins we get in ART? Yes. Yeah, it's okay now. What type of twins we get in ART? We get dizygotic twins. Yes. Okay. Now dizygotic twins, they can be of two different type. If it can be of superfecundation or, yes, superfetation. What is superfecundation? Once they have asked, they have given one pair of twins photo. One was of dark complexion and one was of white complexion, fair complexion. So they have asked it is an example of superfecundation or superfetation. So what was it? What was it? What is superfecundation? It means that the dizygotic twins are formed in the same menstrual cycle just after some gap. And what is superfetation? That the dizygotic twins are formed in the in one cycle and the another in the another cycle. Okay, so in human beings only superfecundation occur. Okay, if the twins will be formed in different menstrual cycle, then what will happen? Yes, then what will happen? प्लीज राइट डाउन व्हाट विल हैपन. जब डिलीवरी के टाइम पे फिर अलग अलग एक बच्चा 8 महीने का होगा और एक बच्चा 9 महीने का होगा. Isn't it? That is what is going to happen, right? So you are going to remember it कि human beings में fecundation ही होता है. What do you mean by the word fecundation? Fecundation का मतलब क्या है? More and more fertility. So if in one cycle more and more twins will be formed, more and more fetus will be there, then only it will be super fertility. Okay, you must not have seen in twins ki one fetus is of 7 month and one fetus is of 9 month. No, right? So in the human beings only superfecundation is there. Okay, no superfetation. If they have given you if they have given you human beings baby, then it will be superfecundation only. Now let us discuss the monozygotic twins. Monozygotic twins is the once the twins was formed, once the one zygote was formed, one sperm fertilized one ova, and now this zygote divided. Okay, that is monozygotic twins. Write down in the chat box, dizygotic is common or monozygotic? Write down in the chat box which is more common. Basic things are asked in FMG. Dizygotic is common or monozygotic? Which one is common? Yes. Which one is more common, dizygotic or monozygotic? Yes. Yes, dizygotic are more common. Yes, very good, Dr. Isra. Very good, Dr. Rachna. Dizygotic is more common than monozygotic. But when they ask you what is more common, they ask you dichorionic, diamniotic, MCDA, MCMA, conjoined twins. Okay, but if in the option dizygotic is given, then you are going to take dizygotic. Okay, so monozygotic twins, they are of different types depending on when that one zygote has divided. Okay, when that one zygote has divided, it will decide ki what is going to be the, yes, how the chorion and amnion will be there. Okay, so now this is up till day 0 to day 4 of fertilization. It is morula, right? This is morula. Now if this morula will divide into two morulas will be formed. Morula is a 16 cell structure. Morula is a 16 cell structure. Now if this morula will be formed, two morulas will be formed. Now each morula will have its own separate chorion and amnion. Okay, each morula will have its own separate chorion and amnion. So if the division occurs in the first 4 days, then the resultant will be DCDA, dichorionic diamniotic. Okay, dichorionic diamniotic. If the division occurs on day 4 to day 8, this one. Now after day 4, blastocyst is formed. Okay, blastocyst is formed after day 4. So now this outer one, this outer structure is known as, outer layer of cell is known as, write down in the chat box, outer layer of cell is known as, It is known as, trophoblast. Okay, outer layer of cell is known as trophoblast. Now when the this structure will divide, there will be beta no division of trophoblast. Okay, there will be no division of trophoblast. This only inner cell mass will divide. Okay, this blue structure, inner cell mass will divide. So as a result, there will be formation of monochorionic diamniotic, right? Monochorionic diamniotic, because trophoblast forms the chorion. Okay, so now there will be, because now trophoblast is not going to divide, right? So there will be monochorionic and diamniotic. Why diamniotic? Because up till this stage there is no formation of amniotic sac. Okay, next is, if the division occur on day 8 to day 12, now there is formation of amniotic sac also. This outer layer is trophoblast and this inner layer is amniotic sac. Okay, now if division occurs on day, yes, come on, day 8 to day 12, it is a table of 4, 0 to 4, 4 to 8, 8 to 12. If division occurs after from day 8 to day 12, then now amniotic sac is also formed. Now only this embryonic disc will multiply and form two embryonic disc. Okay, embryonic disc, right? So now there will be, what will be formed? Write down in the chat box, MCMA, monochorionic monoamniotic, because already before the division everything has been formed. Chorion has been formed, amnion has been formed. So now only two embryonic disc will be formed. Okay, got it beta? Right, after day 12, now the embryonic disc have been, very good, the embryonic disc have been formed. So now there will be formation of conjoined twins or Siamese twins Now tell me which is more common, MCMA, DCDA or MCDA? Which is more common? Yes, which is more common? Write down in the chat box which is more common. Very easy question comes from twins. It has been 1 year, the question has not come. Very easy question comes from twin. Which is more common? Yes, the most common is DCDA. And if it is in the fourth option, they have given you dizygotic, then you will mark dizygotic. Okay, okay. In the preeclampsia, we also did table of 4. Do you remember? No बेटा, actually the Dr. Isra, actually the side वाली slides enlarge हैं. No, actually ना वो side वाली enlarge हो गई हैं. If it is not of much problem, then I think we can continue with this. Yes, we did it for 4 का टेबल हमने प्री एक्लैम्सिया में भी किया था ना, मैग्नीशियम सल्फेट टॉक्सिसिटी के लिए. फॉर व्हाट वाज इट? लेट अस रिवाइज इट. व्हाट इज द थेरेपेटिक लेवल ऑफ मैग्नीशियम? कम ऑन, it is 4 to 8. What is the therapeutic level of magnesium? Yes, what is the therapeutic level of magnesium? Write down in the chat box. 4 to 8. At 8 to 12, knee reflex goes. Knee reflex goes. And at 12 to 16, respiratory system gets effective. Okay. So in preeclampsia, we have to start from 4. Right. But in the twins, we have to start from 0 to 4. Okay. 4 to 8, 8 to 12 and more than 12. In the preeclampsia, we have started from, yes, 4 to 8, 8 to 12, 12 to 16 and more than 16. Is it okay? Is it okay? Now let us see. Let us see how we can evaluate the dichorionicity. Okay. If 2 separate placentas are present, it means it is a dichorionic placenta. If 2 separate placenta are present, it means it is a, come on, if 2 separate placentas are present, it is a dichorionic, right? If a male and female is present, then it means it is a dizygotic twin. Okay. If male and female is present, then it means that it is a dizygotic twin. Okay. If male and female are present, then it means that it is a dizygotic twin. Okay. Is it clear? Now, what is the ultrasound feature of dichorionicity? What we see? Yes, if 2 placentas are present, then we see lambda and twin peak sign. What is another name of lambda sign? Twin peak sign. As you can see in the diagram, this is 2 placentas are present. This is dichorionic, diamniotic and monochorionic, diamniotic. So what happens in dichorionic, diamniotic? What happens in dichorionic? These 2 different placenta, when they are in the uterus, they get fused. They are nearby. Yes. So now see here. If these 2 placentas, if they get fused, if in the uterus they get fused, then they will be separated by, yes, lambda sign is there. See, this is lambda sign. See, between the 2 placentas, there will be lambda sign. Are you getting it? Twin peak or lambda sign, right? And if it is a monochorionic placenta, then there will be which sign? Then there will be which sign? T sign. See, there will be no chorion in between. If there is chorion in between, it leads to lambda sign. If there is dichorionicity is there, then it leads to lambda sign. If there is no dichorionicity, then it leads to twin peak sign. Okay, then it leads to twin peak sign. Very good, very good. Now you tell me, but in the intertwin membrane, the intertwin membrane is made up of, yes, the intertwin membrane is made up of 4 membranes. See? Okay, now the intertwin membrane is made up of 4 membrane. If you can see here, in the dichorionic, diamniotic, 2 amnion and 2 chorion. Very good, Dr. Sumit, very good. And whereas in the monochorionic, diamniotic, it will be a thin membrane, right? It will be a thin membrane. Only 2 amnion will be present. Okay, only 2 amnion will be present. Okay, now the intertwin membrane, in is, if you are given a picture of placenta, then between the placenta, if you get three membranes, it means that it is dichorionic, diamniotic. Okay, getting my point? Getting my point? If you get the placenta of if you are given a placenta in between the two umbilical cords, you have to count the number of layers, right? You have to count the number of layers, right? Okay, now if the intertwin membrane is more than 2 mm, then what is the chorionicity? What is the chorionicity? If the intertwin membrane is more than 2 mm, then it is dichorionic. It means it is a thick membrane, right? It means it is a thick membrane. It means it is a thick membrane, right? It means it is a thick membrane, right? What are the complications of monochorionic twins? What are the complications of monochorionic twins? Yes, twin transfusion syndrome. Twin. Now we are talking exclusively of why it is important to know whether the twin is monochorionic or dichorionic, because the severe complications are linked with monochorionic twins. What complications are there if it is a monochorionic twins? So first complication is twin transfusion syndrome. Okay, so due to why there is twin transfusion syndrome? Because there is single placenta. So if there get deep arteriovenous between the umbilical cord and umbilical vein, there get the anastomosis. What is the staging for? We have to be fast. What is the staging for twin transfusion syndrome? Yes, it is a PYQ. What is the staging for twin transfusion syndrome? Name of the staging. Yes. To diagnose the severity of twin transfusion syndrome, what is the staging? Quintaro staging. Okay, the staging is, come on everyone, be active. Quintaro staging. Okay, so the donor gets oligo. There is transfusion of blood from one twin to another twin. So the donor goes into oligo and the recipient goes into polyhydramnios. Okay, polyhydramnios. Okay, now what is the treatment? What is the treatment? What is the treatment? Fetoscopic laser ablation of that anastomosis. Okay, fetoscopic ablation of that anastomosis, that deep arteriovenous anastomosis. Okay, is it okay? No queries? Should we go ahead? Okay, now the another is TAPS. The another syndrome is TAPS. Twin anemia polycythemia syndrome. Okay, very good, Dr. Sumit. It was Quintaro staging. So twin anemia polycythemia. Very good, Dr. Rachna. Right. So now it is twin anemia polycythemia syndrome. What is difference between TAPS and twin transfusion syndrome? In twin transfusion syndrome, there was deep AV anastomosis. Now in the twin anemia polycythemia syndrome, there is, come on everyone, superficial AV anastomosis. Be active, be active. There is superficial AV anastomosis. Please mark this word, superficial. In twin transfusion syndrome, there was deep. So in twin transfusion syndrome, there was polyhydramnios and oligohydramnios. In the TAPS, twin anemia polycythemia syndrome, there is no TAPS. Sorry, there is no polyoligo. Okay, there is no polyoligo. So that completes your monochorionic twins. Now let us come to monochorionic monoamniotic twins. What is the complication of monochorionic monoamniotic? अब एक ही सैक में आ गए हैं, ठीक है. Now they are in the one sac. Monochorionic monoamniotic twins. Now they are in the one sac. Okay. Now they are in the one sac. Okay. Now what is the specific complication? Cord entanglement. Beta, there will be anemia and polycythemia. Yes, Dr. Rachna, there will be anemia and polycythemia, but there will be discordant growth. One twin will be large and the another twin will be small, but there will be no oligo or poly. If there is oligo and poly, then it is twin to twin transfusion syndrome. Got it, beta? Got it, Dr. Rachna? Got it? So let us see what is the most common conjoined twin? Parapagus. Okay, parapagus. What is the second most common? Thoracopagus. Parapagus means pelvis is common. Pelvis is common. What is thoracopagus? Thoracopagus means thorax is common. Most common is parapagus. Now let us see mode of delivery. Okay, Dr. Rachna has said okay. What is the mode of delivery? Come on. What is the mode of delivery? In the monoamniotic twins, we have always to do cesarean. And when we will do cesarean, the time is 32 to 34 weeks. When we will do cesarean, 32 to 34 weeks. Okay. And in the monochorionic diamniotic and dichorionic diamniotic, we can do normal delivery. And when we will do normal delivery? Yes, when we will do normal delivery, if the first twin is vertex. Okay, if the first twin is vertex. Who is the first twin? The one which is on the lower side, जो नीचे है, the one which is below. That is the first twin. If the first twin is vertex, then we have to go for NVD, right? And if the first twin is not vertex, then we have to go for cesarean. Okay, which is the most common presentation? Vertex. Which is the most common presentation? Vertex. Twins is over. Let us go to RH negative now. Okay, much questions are not asked in RH negative, but still concepts should be clear, so we are doing it. Okay. Yes, Dr. Isra, it means it is lower. Now, if mother is RH negative and father is RH positive, so there are chances that baby will be positive. Then it is a problem. But if mother is negative and father is negative, then it means that there is no problem. So you should know that if mother is negative and father is negative, then no problem. If both are negative, then there is no problem. Problem only arises if mother is negative and father is positive, because then only the baby will be positive. What happens, what the problem happens if the baby is positive? Yes, then at some time, if the positive blood will come into mother's blood, sometime if the positive blood will come into the mother's blood, then what will happen? Mother's blood will form antibodies against the fetal blood, right? And first time these antibodies will be immunoglobulin M, and it will not cross placenta. Okay, but the another time it will be immunoglobulin G, and it will cross the placenta also. Okay, okay, now what will happen if the mother will form antibodies against the fetal blood? What will happen if the mother will form antibodies against the fetal blood? Yes, then hemolysis will occur, right? Hemolysis will occur. Amnestic response will be there. Much larger amount of antibodies will be formed in immunoglobulin G. Then due to this hemolysis, heart will fail. Heart will fail, leading to hydrops fetalis. Is it clear? Is it clear? Okay. What are the causes of this? This is... Yes, Dr. Isra, it is right. Mom forms anti-RH antibodies. Right, very good. So hemolysis will occur, and there will be hypercirculation. The heart of the fetus will fail, leading to hydrops fetalis. This was the example of immune fetal hydrops. Okay. What are the causes of non-immune fetal hydrops? Yes. What are the causes of non-immune fetal hydrops? Congenital heart diseases. If the baby has congenital heart diseases. Number second karan is chromosomal disorder. Okay, chromosomal disorder, especially Turner. Number third reason is parvovirus B19. Why parvovirus B19 causes fetal hydrops? Because parvovirus B19 affects erythroid progenitor cells. Okay, I am telling you again and again that non-immune questions are asked much more than immune. Okay, because non-immune is more common. Non-immune is more common. That is why questions are not asked on Rh negative. They are asking the question on non-immune fetal hydrops. To have Rh negative blood group is very rare. Okay. So focus on this non-immune fetal hydrops. The most common cause of non-immune fetal hydrops is congenital heart diseases of the fetus. Number 2 is chromosomal disorder, Turner's. Number 3 is parvovirus B19 infection. Number 4 is alpha thalassemia. Number 4 is alpha thalassemia. Number 5 is torch infection except rubella. This was the question of INI set November 22. What was the question? Non-immune fetal hydrops is caused by. What was the option? Option was toxoplasma, herpes, CMV, and the fourth option was HIV. Fourth option was HIV. So the answer was HIV. Okay. So first you learn these reasons of non-immune fetal hydrops. Then you go to immune fetal hydrops. Okay. The reason for non-immune fetal hydrops are more commonly asked. Yes, very good, Dr. Sumit. Very good. So don't forget to write, Dr. Sumit, torch. All the torch infections except rubella. In the torch, TO stands for toxoplasma, R stands for rubella, C stands for cytomegalovirus, and H stands for herpes simplex. Okay? Herpes simplex. Right? So, non-immune fetal hydrops is not caused by HIV. Now, let us see how we manage Rh negative patient. Okay, when does we told that whenever fetal blood will go into the mother blood, when the fetus blood go into mother blood. Yes, write down in the chat box, when the fetus blood go into mother blood. Very good, write down in the chat box. Very rarely fetus blood go into mother blood. When the fetus blood goes into the mother blood, very rarely. Fetal circulation is different, mother circulation is different. Their crossover. When the fetus blood go into mother blood, number one, whenever we do a invasive process like chorionic villi sampling, amniocentesis. Yes. Second, it goes in the third trimester. That is after 28 weeks. Fourth, it goes after placenta separation. Okay, fourth it goes. Dr. Isra, remember the another two causes also. Okay, after placenta separation. That is at the time of abortion or at the time of delivery. Okay, is it okay? We cannot stop feto-maternal hemorrhage, but we can stop the antibody formation. How? We cannot stop the feto-maternal hemorrhage. We cannot stop delivery. We cannot stop the third trimester to come. Okay? But we can stop the antibody formation by neutralizing the antigen by the anti-D passive antibodies. Okay, are you getting this? How we treat this patient? How we treat this Rh negative patient? We know that antibodies and that feto-maternal hemorrhage occur at this time. Now we will give anti-D at this time. Now we know now at what time feto-maternal hemorrhage is occurring. So we will not let the mother to sensitize. Okay? We will not let the mother to form the antibodies. Okay? We will not let the mother to form the antibodies. We will kill the fetal antigen by giving anti-D from outside. Okay? What is the normal protocol if Rh negative patient comes and father is Rh positive? So first of all, we get the ICT done. We get the ICT done. We get the antibodies checked at whether there is prior formation of antibodies or not. Okay. So we get the antibodies test done at first week. Okay. If negative patient is coming, Rh negative patient is coming, we check the father's blood group. If the father blood group is positive, then there are chances that the baby will be positive. Now we check that if there is any prior formation of antibodies or not. So with which test we get the ICT, right? Then we get the ICT done. What is the another time we get the ICT done? 28 weeks, right? And third time we get it done at after delivery. Okay, in a patient whose ICT is negative, next time we get ICT done at 28 weeks, because we know at first time we get them. Yes, first time Dr. Rahul is saying 12, 20, 28 weeks. Beta, most commonly this is followed at first visit, then at 28 weeks, then then after the delivery. Okay, if patient is affording, then we do it 12, 20, 28 weeks. Okay, have you got this? Have you got this? Why it is done at first visit? To see that if there is prior antibody formation or not. Why it is done at 28 weeks? To see that if there is, yes, why it is done at 28 weeks? Because we know that in the third trimester there is chances of feto-maternal hemorrhage. Okay, okay, okay. So if ICT is negative, then we give anti-D. If ICT is negative, then only we give anti-D. Okay, if the mother is not making antibodies, then only we should give the anti-D. Okay. Okay. What if ICT is positive? It means that mother is making antibody. What if the ICT gets positive at 28 weeks? It means the mother has started making antibodies, right? So now we have to do the titers. Now we have to do the titers. We will do the titers 4 weekly. Okay, once the titer are more than 1:16, then we will get which test? This is a PYQ. If the titers cross more than 1:16, what is the next step? Yes, Dr. Rahul, you are right. To see whether feto-maternal hemorrhages है कि नहीं ये देखने के लिए. Very good. Now you tell me, if the titer cross 1:2, if the titers cross 1:2, no, Dr. Isra. Now we will do NCA Doppler. Middle cerebral artery Doppler. What is its advantage? You know that whenever anemia occurs in our body, then what happens? Dr. Iman Abdullah, good evening. What happens when titers cross? Then it means antibody titer is causing anemia. Now we have to see that anemia is significant or not. Whenever there is any anemia in the body, our body preferentially give blood to the brain, right, and heart. So the blood flow to the brain and heart increases in anemia. So that is seen by NCA Doppler. Write down in the chat box. If any question will come, then this question will come. That if the titer cross 1:16, what is the next step? Already it has come. Already it has come in the exam. Increased velocity of the blood in which artery, Dr. Iman? Dr. Isra, not cerebral ischemia. First there is, very good Dr. Rahul. Dr. Isra, there will be increased blood to the brain in the fetal anemia. There will be increased blood flow to the brain in fetal anemia. Yes, very good. Dr. Isra, is it okay? Okay. Now, if the NCA Doppler is more than 1.5 MOM, it means that, what it means? Now if the flow is also increased, no, Dr. Rahul, please see here. If the period of gestation is more than 34 weeks, then deliver. Okay? If the period of gestation is less than 34 weeks, very good, Dr. Iman, very good. Very good, Dr. Isra. If the period of gestation is less than 34 weeks, then we have to do cordocentesis to get the HB done of the fetus. Now we get the HB done of the fetus, and if HB is less than 8, then we get the intrauterine blood transfusion. Very good, Dr. Rahul, very good. MOM is, what is MOM? Median, mean of mole of median. It is velocity unit. It is the velocity unit. Okay? Like MOM is something like mode of median. Multiple of median. Dr. Isra, it is multiple of median. It is the velocity unit. Is it okay? Now you know everything. Median. It is not medium, it is median. Okay, what is ROGAM? What is ROGAM? What is the dose of ROGAM? Second expected question. What is the dose of ROGAM? Yes, Dr. Isra, it is right. What test we do before giving ROGAM? ROGAM is anti-D. Okay? ROGAM is anti-D. We first test to give before giving ROGAM is ICT negative. ICT should be negative. Okay? If ICT is positive, it means that mother body is making large amount of anti-D. No need to give such a costly injection, beta. No need to give such a costly injection. Right? So dose is 300 microgram. This was the PYQ of FMG. What is the dose? Very good, Dr. Rahul. It is 300. So you have to remember 300. Yes, not Rosity test, Dr. Rahul, not Rosity test. The test which you have to do is before giving NTD ICT. Mother should not be making ICT, antibodies. Okay, the test, Dr. Rahul, it is ICT. The test should be ICT. ICT is negative, then only we will give. Is it okay? Okay. Okay. Now tell me, what is the ideal time to give what is the ideal time to give ROGAM? Is it at 28 weeks or is it at after delivery? Tell me, all those who are watching, please tell me what is the ideal time to give NTD? After 28 weeks or after delivery? No, 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 beta. Ideal time to give NTD is after 28 weeks. Okay? Okay, is it okay? No, if ICT is positive, then we have not to give Dr. Sumit NTD. No, if ICT is positive, then we have not to give at 28 weeks. Okay? If ICT is positive, then it means that mother is making antibodies. Once again, we repeat the management. First time, if a lady comes to us with RH negative, if a RH negative lady comes to us, then what we will do? We will check the husband's blood group. If the husband blood group is positive, then we will check that already the mother is making antibodies or not. That we check by doing ICT test. Already the mother has been sensitized or not. Is it okay? If first time the lady comes, beta, but if, Dr. Sumit, ICT is only positive if IgG is positive. Okay. Okay, ICT is only positive if IgG is positive. ICT is not positive if IgM is positive. Okay. Why to give NTD if mother is making such a large amount of NTD? We give NTD only to neutralize the fetal blood, fetal antigen. Okay, if already the mother has been sensitized, we will not give NTD. Let's discuss its management once again fastly. If on the first visit, first antenatal visit, if a mother is coming with negative blood group, we will check the father's blood group. We will check the father's blood group. Okay, if RH negative mother is coming, then we will check the father's blood group. If it is positive, then we will get the ICT done. If ICT is negative, then we will get the second type ICT done. Okay, at 28 weeks. Because we studied that at 28 weeks, what happens? इन द थर्ड ट्राइमेस्टर फीटो मेटरनल हैमरेज के बहुत चांसेस हैं. There are increased chances of feto-maternal hemorrhage and after 28 weeks. So once again we will get ICT done, and then we will give the anti-D injection if ICT is negative. Okay, then after delivery again we will get the we will give the anti-D if direct Coombs test is negative. Okay, if direct Coombs test is negative, then we will again give anti-D. So 2 times anti-D we give. One at 28 weeks, one at after delivery, and 3 times we get the Coombs test done. One at first visit, another at 28 weeks, third at direct Coombs test. After delivery, is it clear? Is it clear to everyone? The management of RH negative if ICT is negative. Dr. Isra, is it clear? What if ICT comes positive? If mother starts making antibodies, okay, then we have to get the ICT titers done 4 weekly. Now, once the ICT comes positive, then we will get the ICT titers done 4 weekly. If the titers cross 1:16, if the titers cross 1:16, if the titers cross 1:16, it means that antibodies are causing anemia. If the titers cross 1:16, they are more than 1:16. Now we will get MCA Doppler done weekly. If the MCA Doppler is more than 1.5 MOM and the period of gestation is less than 34 weeks, then we get Cordos fetal HB done by cordocentesis. Okay, then we get fetal HB done by cordocentesis. If fetal HB is less than 8, then we give intrauterine blood transfusion. Is it okay? Any problem? We give NTD at 2 times, 28 weeks and after delivery. Okay, we give NTD at 2 times. ठीक है, NTD 2 times देते हैं हम at 28 weeks and after delivery. If they ask you choose one, then you will choose 28 weeks. If they ask you to choose one, then you will choose 28 weeks. Okay. Before giving NTD, you should check the antibody formation in the mother by ICT or DCT. Okay. Now 300 microgram of Rogam or NTD neutralize 15 ml of fetal blood. Right? 300 microgram of NTD neutralize 15 ml of fetal RBC. Right? How we calculate how much blood has crossed or not? For all those who can get confused between these tests, please see here how we calculate. Yes, the fetal blood is resistant to, please tell me, acid and alkali both. Fetal blood is resistant to acid and alkali both. Okay, so fetus has came outside, right? Delivery, after delivery, fetus is in our hand. Fetus is a newborn, right? So we first of all we get the blood group of the fetus done. If it is positive, now we have to calculate how much feto-maternal hemorrhage has occurred, right? How much feto-maternal hemorrhage has occurred. Okay, how we will calculate? In the fetus blood we will put alkali. Fetus blood is resistant to acid also and to alkali also. Okay, fetus blood color does not change on putting acid and alkali. So in the case of Rh negative, we do acid elution test. In the case of vasa previa, we do the alkali denaturation test. Okay, we do the quantitative measurement. How much? Quantity measurement. How much blood has crossed? Here we see which is the difference, which RBC is of fetus and which is of mother. RBC, red blood cells. We see the difference between the fetus and maternal red blood cell by making a slide like this. We take the fetus blood, put the acid. Mother blood changes color on putting acid. Okay, whereas fetus blood is like this red color. Right? We calculate the fetal RBCs, red blood cell. So if they ask you that acid test is done in, then you will say acid test is done in Rh negative. Alkali test is done in vasa previa. Alkali test is done in vasa previa. If they ask you blood, fetal blood and maternal blood or qualitative test, then you will say it is alkali test, single denaturation test. This one is done bedside, vasa previa test, whereas this one is a lab test. Is it clear? समझ में आ रहा है? Okay, now let us start with preterm labor pains. What is the definition of preterm labor pain? PYQ. Question is expected in your exam. If the uterine contractions is more than 4 in 20 minutes or more than 8 in 60 minutes. What is preterm labor pains? If the uterine contraction is more than 4 in 20 minutes or more than 8 in 60 minutes, it is preterm labor pains. Okay, Sir, plus, one more criteria. Cervix dilatation should be more than 3 centimeter, and or cervix length should be less than 2 centimeter. Right? What is the definition of preterm labor pains? Write down: uterine contractions more than 4 in 20 minutes or more than 8 in 60 minutes. That is 1 hour. So it means that they are labor pains, preterm labor pains. Okay. Now what next? One more criteria you have to add. Either of these two. What are those two? Cervix dilatation should be more than 3 centimeter or cervix length should be less than 220 mm. Yeah, 2 centimeter. Is it okay? What do you mean by that cervix length is less than 20 mm? Tell me that cervix effacement is more than 80%. What is the investigation test for preterm labor pains? What is the investigation for preterm labor pains? Fetal fibronectin. Fetal fibronectin, if it is present in cervicovaginal secretions between 24 to 34 weeks, it means that the preterm labor pain is positive. Getting? Are you getting it? Okay. So, along with labor pains, along with contractions, very good. Along with contractions, you have also to see cervix dilatation and cervix effacement. Cervix effacement is also measured with cervix length. Okay. Right. Another test which you can do is fetal fibronectin. What are the risk factors? What are the risk factors? What are the risk factors for preterm labor pain? Most important, previous history of preterm labor pains. Previous history of preterm labor pains. Over-distended uterus. Over-distended uterus cause preterm labor pains. What are the reason of over-distended uterus? Yes. Yes, students, what are the cause of over-distended uterus? Please tell me. Twins. What are the other causes? Polyhydramnios, macrosomia. More is the uterus distended, more the pain it causes. More early the pains are, right? The another cause is abruption. Why in abruption there is preterm labor pain? Please write down in the chat box. Abruption is a very solid cause of preterm labor pains. Why in preterm labor pains why in abruption there are preterm labor pains? Because thromboplastin which is released in abruption is a potent uterotonic. Very good, Dr. Iman. Very good. Very good. Very good. Thromboplastin which is released in abruption is a very potent uterotonic. Okay. Short cervix or cervix surgery. For example, LEAP or conization. That is how they give integrated questions. Patient had cancer cervix. Patient went under conization. What is expected? Preterm labor pains are expected. Okay. Last but not the least is infection or PROM. Last but not the least is infection or PROM. If the patient had short cervix or previous history of preterm labor pains, what prophylaxis we give? What prophylaxis we give? Dr. Isra, are you there? What prophylaxis we give if the patient had previous history of preterm labor pain or patient had short cervix? Come up. We give 17-hydroxyprogesterone. Okay, we give 17-hydroxyprogesterone to the patient, and if the patient had short cervix, then we undergo answer class. Very good, Dr. Iman. And the prophylactic procedure is Surclass and 17-hydroxyprogesterone drug. They ask you which is the drug of choice for prophylaxis of preterm labor pain. Answer is 17-hydroxyprogesterone, not simple progesterone. Along with Encirclage, we also give the drug 17-hydroxyprogesterone. Okay, what is the treatment? Patient had undergone on. Yes, what is the treatment? We will give glucocorticoids. Two glucocorticoids which can be given are dexamethasone and betamethasone. Very good. Dexamethasone and betamethasone. Write down its doses. Write down the doses of dexamethasone and betamethasone. The doses of dexamethasone is 6 mg, 4 doses, 12 hourly. Doses of betamethasone is 12 mg, 2 doses, 24 hours. Okay, is it okay? Yes, tocolytics are only given if it is less than 34 weeks. If pregnancy is less than 34 weeks, then only we give tocolytics. Last time PYQ है FMG का on tocolytics drug. Listen carefully. Question is expected from this topic. Tocolysis. Indomethacin is a prostaglandin synthetase inhibitor. Is to be given if the period of gestation is less than. Very good. Dexa 4, beta 2, gaps. Yeah. Indomethacin is to be given only if the period of gestation is less than 32 weeks, as it causes premature closure of ductus arteriosus. Magnesium sulfate is to be given, another tocolytics, if the period of gestation is less than 32 weeks. It also causes neuroprotection. Very important. Magnesium sulfate, another effect, neuroprotection while giving tocolysis. Beta agonist. Lot of questions are asked on beta agonist. Please listen carefully. What are the name of beta agonists which are used as tocolysis? Terbutaline, ritodrine, isoxsuprine. Okay. The name of the beta agonist used as tocolytics: terbutaline, ritodrine, isoxsuprine. Okay, these are the name of the beta agonists. What is its side effects? As they are beta agonists, they causes vasodilation. They cause, very good Dr. Iman, very good. They cause vasodilation, hypotension, and tachycardia. Quite frequent you forget what are the iron status while taking beta agonist. जब हम बीटा एगनिस्ट लेते हैं तो क्या होता है, हाइपोटेंशन हो जाती है, वॉजोडाइलेशन हो जाता है. इज डू एनीवन हैज प्रॉब्लम विद हिंदी? राइट डाउन इन चैट बॉक्स. वी विल डू इट इन हिंदी देन. हिंदी में कोई प्रॉब्लम तो नहीं है बच्चों? हिंदी में करवा दें, इट विल बी फास्ट देन. प्लीज राइट डाउन. कैन वी डू इट इन हिंदी? Please write down Hindi or English in the chat box. You are asking. Dr. Rahul, can we do it in Hindi? ओके. देखो बीटा एगनिस्ट के साइड इफेक्ट्स पूछे जाते हैं, ठीक है. तो क्योंकि बीटा एगनिस्ट, ओके, बीटा एगनिस्ट के साइड इफेक्ट्स पूछे जाते हैं. बीटा एगनिस्ट हाइपोटेंशन करता है, सारे आयंस को ये हाइपो कर देता है, ठीक है. पिछली बार नो डॉक्टर ईमान, हम 2 टोकोलिटिक्स नहीं दे सकते हैं. वी कैन नॉट गिव 2 टोकोलिटिक्स डॉक्टर ईमान. वी हैव टू गिव ओनली 1. ओके, वी कैन नॉट गिव 2 टोकोलिटिक्स. ओके, ठीक है. तो वॉजोडाइलेशन हो जाता है, राइट. तो जब हम बीटा एगनिस्ट देते हैं तो बीटा एगनिस्ट जो है हाइपोटेंशन टैकीकार्डिया कर देते हैं. सो इसलिए जो है सारे आयंस का. ओके डॉक्टर ईमान, वी विल कंटिन्यू इन इंग्लिश. ओके, सो बिकॉज बीटा एगनिस्ट causes vasodilation, so there is hypotension. Okay, so all the ions they go in hypostage. Okay, all the ions go in hypostage. Hypokalemia, hyponatremia, even once there occur hypoglycemia, but due to the body stress there is hyperglycemia. So you have to remember that there is high output cardiac failure. So it is contraindicated in heart diseases and diabetes mellitus. Is it okay? The beta agonist tocolysis is contraindicated in heart diseases and diabetes mellitus because beta agonist tocolysis causes hyperglycemia and high output cardiac failure. Okay, beta agonist causes hyperglycemia and high output cardiac failure. Is it okay? Write down in the chat box what happens with terbutaline and ritodrine, hypokalemia or hyperkalemia. Write down in the chat box. Everyone. Very important question. It is last year PYQ. Last time PYQ, terbutaline causes hypokalemia or hyperkalemia. Write down in the chat box, everyone. The drug of choice for the tocolysis is calcium channel blocker nifedipine. Okay, the drug of the choice for the tocolysis is calcium channel blocker nifedipine. And what is its side effect? Hypotension and headache. Hypotension and headache are the side effects of nifedipine. Okay, hypotension and headache are the side effects of nifedipine. It is drug of choice. Okay. Yes, Dr. Sumit, it is hypokalemia. Very good. Hypokalemia it causes. Yes. Okay. Let us discuss the signs of intrauterine death. Again, it is a PYQ. Very good. What is Robert's sign? Robert's sign is the first sign of intrauterine death. Because you all know heart undergoes arrest, so there is no blood flow, and as a result there is gas in the large vessels. Okay, this gas in the large vessel can be seen on X-ray, and this is known as Robert's sign. What is Robert's sign? Sign of intrauterine death. Robert's sign is gas in the large vessels. Why there is gas in the large vessel? Because after death of the fetus, there is cardiac arrest. Cardiac arrest. Very good, Dr. Iman. Very good. Due to the cardiac arrest, there is stoppage of the blood flow. As a result, there is gas in the large vessels, which can be seen on X-ray. Okay, which can be seen on X-ray. Right? Another is the Spalding sign. Earliest sign is Robert's sign. Robert's sign is the earliest sign. What is Spalding sign? Spalding sign is overlapping of the skull bones, because it is seen after 7 days. The brain matter undergoes liquefaction. Brain matter, cerebral cortex undergoes liquefaction. So there is overlapping of skull bones, which is called Spalding sign. Spalding sign is seen on X-ray. Spalding sign is seen on X-ray. What is Ball sign? Because this is seen after 10 days, last to come. Right? This is last to come after 10 days. There is hyperflexion of fetal spine. There is hyperflexion of fetal spine. Very good. This is known as Ball sign, because all the intestine and all the viscera undergoes liquefaction. So there is hyperflexion of fetal spine. This is also seen on ultrasound. Very important topic now. Manning score. Manning score. Okay. Manning score or biophysical profile. Sure, question is going to come on from this topic. Manning score or biophysical profile. There are 5 components of Manning score. Fetal movement, fetal breathing movement, fetal tone, then are AFI and NST. Okay, AFI and NST. AFI and NST are most important. That is why we say it. That is why we say it as modified biophysical profile. Okay, modified biophysical profile. Right? To every it is given 2 marks. 2 score is given to every component. Total score is 10. 8 to 10 score is normal. 8 to 10 score is normal. Score 6 plus is equivocal. Score of 6 plus is equivocal. 8 to 10 score is normal. Score of 6 plus with normal AFI is equivocal. And if the score is 0 to 4, it is pathological. If the score is 0 to 4, it is pathological. Okay. How you will remember these 5 components? 2 movements are there, beta. Fetal movement and fetal breathing movement. Another is fetal tone. AFI and NST are modified biophysical profile and they are most important. If the Manning score is 0 to 4, then immediate termination. If the Manning score is 0 to 4, then immediate termination is to be done. Sure question on this slide. Question will come from this slide. What is Manning score? What is Manning score or biophysical profile? What is modified biophysical profile? What does Manning score tells? Manning score tells us about fetal status. Now let us discuss umbilical Doppler. Umbilical Doppler is done to see fetal IUGR, fetal intrauterine growth restriction. Okay, fetal IUGR. During the systole, as the heart is contracting, so the wave goes up. But during the diastole, the wave is downward because it is due to the recoil velocity. Right? It is due to the recoil velocity. Okay, so this is normal umbilical Doppler. A long systolic wave and a small diastolic wave. Again a long systolic wave and again a small diastolic wave. Okay, umbilical Doppler is to see the IUGR. Right? If there is no diastolic blood flow, it is known as absent end diastolic flow. What is it? It is told. What is absent end diastolic flow? Yes. Absent end diastolic flow is, write down in the chat box. Write down in the chat box, what does AEDF stands for? Absent end diastolic flow. Okay, and when it is seen? When is absent end diastolic flow seen? In the case of uteroplacental insufficiency, there is no diastolic blood flow. Okay, there is no diastolic blood flow. Right? And termination is to be done at 34 weeks. Termination is to be done after 34 weeks. If there is absent, yes, very good. If there is absent end diastolic flow, then termination is to be done at 34 weeks. Okay. Now, if this Doppler waves are seen in the opposite direction, in the umbilical Doppler, then it is known as reverse and diastolic flow. And termination is to be done if period of gestation is more than 32 weeks. Very good. Okay. What is the period of termination? This is something new. Question can be asked. On new FMG, people ask question. If there is absent end diastolic flow, then termination is done at 34 weeks. If there is reverse end diastolic flow, the flow is going in reverse direction, then termination is done at 34 weeks. When is uterine artery Doppler done? NEET PG PYQ. NEET PG people are only making your question. Uterine artery Doppler done at 11 to 13 weeks. Tell us about, very good Dr. Iman, 11 to 13 weeks. Yes, it tells us about premature onset of preeclampsia. What is the relevance of uterine artery Doppler? When we do uterine artery Doppler, we do it in the first trimester. To predict, it helps in the prediction of preeclampsia. So today we have done the Doppler. Write down in the chat box, when we do MCA Doppler, when we do umbilical Doppler, and when we do uterine artery Doppler. Write down in the chat box. Doppler is completed. Then we are coming on antenatal fetal surveillance. Okay. Antenatal fetal surveillance. Taking care of the fetus while the fetus is inside the uterus. How we see that fetus is healthy or not? We ask the mother to do kick count. Right? We ask the mother to do kick count. How much is the normal? Very good, Dr. Isra. How much is the normal kick count? When is the kick count done? After the meals. 1 hour after the meals, fetal kick is counted by the mother, and we take 3 meals. So 3 times in a day we calculate the fetal kick count. 3 times in a day we calculate the fetal kick count. And 4, very good Dr. Isra. Dr. Sumit, we don't do umbilical Doppler. Umbilical Doppler is done in preeclampsia or IUGR. MCA Doppler is done in RH negative. Umbilical Doppler is done in preeclampsia or IUGR. Uterine Doppler is done in prediction of preeclampsia. Okay, Dr. Isra, it is not done for 10 to 12 hours. It is done only 1 hour after the meal. Kick count is done 1 hour after the meal. And then we multiply it by 3 and add 4. Okay, and that should be more than 10. Yes, that should be more than 10. Okay. The another way of doing antenatal fetal surveillance is NST. What all we see in NST? Can anyone tell me? What we see in NST? Can anyone tell me? We see that there is accelerations are present or not. What do you mean by accelerations? What is acceleration? rise of the fetal heart rate more than 15 beats for more than 15 seconds. Right? What is fetal acceleration? Rise of the fetal heart rate. Fetal heart rate. Rise of the fetal heart rate more than 15 beats. If the fetal heart rate was 120, it goes more than 135, and it is for more than 15 seconds. Okay, this is the NST. As in NST there is no labor pains, so down there is fetal movements are written. NST is done antenatally. एंटीनेटल करते हैं. We do it antenatally. Okay, we do it antenatally. That is during pregnancy, not intranatal, not within the labor pains. Okay, so see, with the fetal movement, here there is fetal movement, and you can see that fetal heart rate is rising. Here there is fetal movement, and you can see that fetal heart rate is rising. Acceleration are present. So, how much acceleration should be present? 2 acceleration, 2 or more than 2 acceleration should be present in 20 minutes. That is the criteria of normal NST. Right? Another criteria is beat to beat variability. What is beat to beat variability? Please tell me, what is beat to beat variability? See, this line, this baseline should not be straight. I am here not talking about acceleration. The baseline should not be straight. Okay, the baseline should not be straight. It should go up and down, beat to beat variability. Number 3, there should be no deceleration. No deceleration. So 3 points which you have to see in NST. Number 1 is acceleration. Number 2 is beat to beat variability. Number 3 is no deceleration. Have you got it? Have you got it? So, antenatal surveillance is done by fetal kick count by mother. Fetal kick count by the mother, biophysical profile, each square equals to 5 weeks, Dr. Isra. There is nothing short or long variability. Variability should be present. Each square equals to 5 beats. Okay. So how we do antenatal fetal surveillance? We ask the mother to get the fetal kick count. Right. We do the biophysical profile. Okay. Third is we do NST after 32 weeks. And in NST we see 3 things. acceleration with fetal movement. Number 2 is acceleration with fetal movement. Number 2 is beat to beat variability. And number 3 is no deceleration. Okay. Any problem? Please write down. Now we are coming on intranatal fetal surveillance. Okay, intranatal fetal surveillance. Intranatal fetal surveillance is done with labor pains. Okay, intranatal fetal surveillance is done with labor pains when the patient is in labor pain. Now the test which we will do is CTG. The test which we do in intranatal fetal surveillance is CTG. Okay. Okay. This is the mnemonic for intranatal fetal surveillance. Wheel chop. The mnemonic for intranatal fetal surveillance is wheel chop. Here we have to see decelerations are of which type. Deceleration are of which type. Okay. If the decelerations are of variable type. What do you mean by variable deceleration? See, in the labor pains, this is CTG. Right? In the CTG, at the lower side, there will be contractions. Contraction wave will be there on the lower side. Okay, are you getting it? Okay, what is variable deceleration? Variable deceleration means contraction waves and deceleration waves, they have no relation. What do you mean by variable deceleration? Variable deceleration means that contraction waves and deceleration waves have no relation. See, this is the contraction peak and this is the deceleration peak. No relation. See, no relation. Fetal kick count, how we do fetal kick count? Dr. Iman is asking. Fetal kick count we ask the lady to count the fetal kicks after every meal. Okay. Usually a human beings take 3 meals. Right? So we ask to count the fetal kick count after every meal. After every meal, the female has to count the fetal kick count for 1 hour. Okay. For every day, you will count after every meal. For example, if after breakfast, Dr. Iman has asked about fetal kick count. See how we do fetal kick count. After every meal, after breakfast, lady will count the kicks for 1 hour. After lunch, she will count for 1 hour, and after dinner, she will count for 1 hour. Okay. For example, after breakfast, if it was 2, after lunch, if it was 3, and after dinner, it was 2. So we will add this all. 2 plus 2, 4 plus 3, 7. And in this 7, we will add 4. Okay. And this thing should be more than 10. Okay, is it clear, Dr. Iman? So here we were talking about CTG, right? So variable deceleration, what are variable deceleration? Variable deceleration is there is no relation of contraction peak and deceleration dip. You can see there is no relation. These type of decelerations are known as variable deceleration. There is no relation between the contractions and deceleration dips and contraction peaks. Okay, now there can be early deceleration, right? What are early deceleration? That when there is contraction peak, the deceleration peak and the contraction peak coincides, right? What is early deceleration? Early deceleration means deceleration is coming before the contraction. Early deceleration means deceleration is coming before the contractions. You can see here. This is deceleration dip and this is contraction peak. It is coming just before the deceleration. Is it okay? This is known as early deceleration. What are late decelerations? Late deceleration means deceleration is coming after the contraction. Okay, you can see here, this is contraction peak and this is deceleration dip. See, first contraction peak comes, then deceleration dip comes. Again, this is contraction peak, this is deceleration dip. This is contraction peak and this is deceleration dip. This is contraction peak and this is deceleration dip. Okay, so if the deceleration is after the contraction, it is known as late deceleration. See, first contraction peak is coming, then deceleration is coming. Okay, now let us see what this. The variable deceleration is seen in cord compressions. When cord compression is there. Okay, when cords compress, there is variable deceleration. Early deceleration are seen when there is head compressions. Okay, head is compressed by the vagina tone. Vaginal distension, that is in the second stage. Late deceleration is seen in uteroplacental insufficiency. So we have to do cesarean. Only the late deceleration are significant. Only the late deceleration are significant. No other are significant. Cesarean is to be done only if there is late deceleration. Cord compressions and head compressions, that is variable deceleration and early decelerations, are not relevant. Is it okay? No, Dr. Isra, only late decelerations are warning sign. Only the late decelerations are warning sign. Okay, that is why we teach that no need to worry about variable and early deceleration. Okay, no need to get fear from this. Sinusoidal pattern is seen in fetal anemia. What is sinusoidal pattern on CTG? This is the sinusoidal pattern. Sinusoidal pattern on CTG is seen in fetal anemia. Is it okay? Is it okay? So, this is all about intranatal fetal surveillance. So, tell me if there is contraction wave and fetal heart rate wave, then it is CTG or NST? Yes, Dr. Sumit, we do cesarean. Uteroplacental insufficiency, fetal hypoxia is there. Now you tell me. What is this? What is this? This is NST or CTG? Write down in the chat box. Is this NST or CTG? Yes. What is this? This is NST or CTG? Dr. Sumit, if fetal movements are written, then it is NST. Please see here carefully. This is NST. This is not CTG. See here, downward it is written fetal movements. Dr. Sumit, is it clear to you? Bachche, it is clear to you? Yes, Dr. Isra, you are right. It is CTG. Very good. Very good. Very good. Okay. Now you know what is difference between NST and CTG. Very good. Very good. Very good. Let us start with type of pelvis. A lady during labor presented with occiput posterior position. Lady has come to us with occiput posterior position. Okay. Manual rotation was tried, but it was unsuccessful. The manual rotation was tried, but it was, what is the pelvis type? Manual rotation is unsuccessful in occipito-posterior. What is the pelvis type? Please write clearly what you want to write. Late deceleration or early deceleration? Please write carefully. Manual rotation. Manual rotation was unsuccessful. The answer to this is anthropoid. Answer to this is anthropoid. It is not android, it is anthropoid.